Hi, I'm Dr. Matthew Hannibal, and welcome to my video on CON laws. What are CON laws, and what are they for? CON stands for Certificate of Need. According to the National Conference of State Legislators, these laws are state regulatory mechanisms for establishing and expanding healthcare facilities. They, quote, prohibit healthcare providers from acquiring, replacing, or adding to their facilities or equipment, except in specified circumstances. These specified circumstances constitute the need. Their intent is to control costs by restricting duplicative services and determining if new capital expenditures meet a community need. CON laws can apply to a multitude of facilities and services, including acute care hospitals, operating rooms, technology services such as MRI and CT scanners, nursing care facilities, adult care home beds, home health agencies, hospice care, and up to 20 others. But why would legislators believe that these laws would accomplish the goal of cost savings? The answer is Romer's Law, deduced by UCLA public health researcher Milton Romer in a 1959 paper. It states that, quote, in an insured population, a hospital bed built is a filled bed. Romer's Law is thought to be a result of the moral hazard of an insured population that will overconsume services if capacity is available. Also, if excess capacity exists, facilities may charge higher prices to cover costs of the unused capacity and create price inflation. Although Romer's Law was found not to always hold true as early as 1978, it remains the underpinning of CON laws. CON laws have fallen in and out of favor in the political arena. The first concept of CON was seen in New York in 1964. The Social Security Act of 1972 under the Nixon administration created federal funding for states that adopted CON laws, and it became federal mandate with all states participating with the exception of Louisiana by 1982. However, CON laws were not found to curb healthcare spending, and the mandate and the federal funding was repealed in 1987. The Obama White House recommended the repeal of CON laws, and in a 2018 report issued by the Trump White House and written by the Departments of Health and Human Services, the Treasury, and of Labor, it found that state policies that restrict entry into provider markets can stifle innovation in more cost-effective ways to provide care while limiting choice and competition. And it made several recommendations, including state action to repeal or scale back Certificate of Need laws. Currently, 35 states retain highly variable types of CON laws. CON laws have been a divisive issue in many states, often with CON holders, hospital systems, and lawyers on one side, and physicians and non-CON holders wanting to enter the market on the opponent's side of these laws, with payers and politicians somewhere in between. Proponents of CON laws argue that healthcare cannot be considered as a typical economic market because physicians, not patients, are doing the ordering. CON programs limit spending, distribute care to rural or disadvantaged populations, and do not create a barrier but provide for an evaluation. They also suggest that removal of CON programs will create low-volume facilities that would provide lower quality as a result. And this would allow money-hungry, greedy doctors to cherry-pick and treat only insured patients at their convenience, while leaving the hospitals to manage the after-hours complications and the indigent care. Opponents argue that CON programs reduce price competition, are difficult to evaluate due to state variability, allow for political influence, which can invite manipulation and abuse, create a lack of competition, which encourages construction and additional spending, and limit appropriate facility expansion because predicting the best interest of a community isn't always clear. Also, Alaska House of Representatives member Bob Lynn argued that true motivation behind Certificate of Need legislation is that large hospitals are trying to make money by eliminating competition, under the pretext of using monopoly profits to provide better patient care. So who's right? Are hospitals trying to obtain monopoly profits, or are greedy doctors trying to cherry-pick cases? And where's the patient in all of this? Are CON laws providing better access, quality, and value to patients in 2019? Matthew Mitchell is a George Mason University Senior Research Fellow, Director of the Equity Initiative, and is an expert in CON laws. He tried to answer that very question in an article in Managed Healthcare Executive. Dr. Mitchell found that access in non-CON states improved as economic theory would predict when supply is no longer restricted. He also found the facts did not support the arguments for CON laws providing more rural and indigent care. There were actually more rural facilities and equivalent charity care in non-CON states. What about quality? The argument is that CONs allow fewer facilities with higher volume and therefore better quality. But we also know that competition tends to improve quality. Dr. Mitchell turned to a study by Stratman and Willey, who mined the CMS database and found that non-CON states had significantly lower mortality rates for pneumonia, heart attack, heart failure, and surgical patients with treatable complications. So, improved quality in CON states is questionable at best. What about value and cost? To answer these questions, he reviewed 2 decades worth of peer-reviewed journals and performed a meta-analysis. Taken as a whole, the literature suggests that CON is associated with both higher per-unit costs and greater total expenditures. So why are CON laws still around? Why haven't politicians changed the laws if they aren't providing better access, quality, or value? Is Dr. Mitchell wrong? If you can't trust an expert in the field, who can you trust? To figure this out, I decided to dig into the specifics of North Carolina CON laws and to ask somebody I could trust. I sat down with Dr. Richard Bruch. He practiced orthopedic surgery for 34 years. He was the president of the North Carolina Medical Society, spent years on Capitol Hill as a professional lobbyist, and was the 2020 American Academy of Orthopedic Surgery Distinguished Congressional Ambassador Award winner. Although he was an owner and chairman of a CON-approved hospital and ambulatory surgery center in North Carolina, he has been a strong advocate for CON reform or repeal. What are his thoughts on current North Carolina CON laws?
It was a program that was meant good things, right things, but it just hasn't worked out. And in our particular county, Durham County, the big health system wants only 100% control over every hospital bed and every operating room in the county. That would be best, right?
As it turns out, North Carolina CON laws are some of the most stringent in the country. North Carolina CON laws are overseen by the North Carolina Division of Health Service Regulation. There are then 2 separate entities within that division: the State Health Coordinating Council, or SHIC, who determines the need for regulated facilities, and the Certificate of Need section, which determines the applicant awarded the CON certificate. The SHIC is made up of 28 members appointed by the governor, many of whom either possess CONs or directly benefit from CON ownership. The SHIC makes the State Medical Facilities Plan, or the SMFP, which is an extremely complicated 450-page document that has unique formulas for each of the 30 entities it regulates. It seemed to me that this would be a conflict of interest for those writing the SMFP to potentially benefit from its recommendations. So I asked Dr. Bruch, who sat on the SHIC for 10 years, about the conflict of interest issue.
I remember specifically talking with Steve Keene, the general counsel of the Medical Society. I said, well, I have a conflict of interest because I'm board chair of the physician-owned hospital in town and a minority owner. He said, don't worry about it. Everybody on the SHIC, the State Health Coordinating Council, has a conflict. And I was a very minority voice.
That appears unethical to me.
What's fascinating about the State Health Coordinating Council, the body that sets this need formula, is that it does not conform to the state ethics laws because it's an advisory committee for the governor. The governor is the one who makes the final decision, and that's how they get around the conflict of interest requirement.
Interesting. So at least they don't get a vote on the state medical facility plan. But how complicated can the plan be?
Well, how complicated can it be? the hospital association pushed for reappointment of one member who had termed out because, according to them, she was the only person who understood the formulas. It can be very complicated.
So, as it turns out, the state medical facility plan is so complicated, no one fully understands it, and the governor has never added more than a one-page revision. In effect, the SHIC does set the policy. So what does it take to get a CON? Well, it takes money. Filing a petition for need costs $15,000. If need can be established, a consultant will need to complete the CON application, which costs $50,000. And it is so complicated it is rarely done correctly the first time, even by a professional. Then, if a CON is awarded, it is provisional and can be contested and appealed by anyone for anything. Even if a CON holder is simply moving the facility within its county or refurbishing an outdated facility. This process can take years and cost hundreds of thousands of dollars, with no guarantee of success. And what is the effect of a policy set by individuals with conflict of interest? Let's look at regulation of operating rooms, or ORs, in North Carolina as an example. We know that it costs Medicare considerably less to have patients go to ambulatory surgery centers, ASCs, rather than have inpatient surgery. From the Medicare website, it costs Medicare nearly $3,000 less for a patient going to an ASC for the same procedure. This is clearly a cost savings and was true of 15 procedures I checked done in the ASC setting. Clearly, more capacity and access to ASCs would help contain costs. However, CON laws do not discriminate between expensive hospital ORs and ASCs. In fact, the SFMP allows for procedure rooms. These rooms can be built just like ORs, and any surgery can be performed in them without restriction. To receive payment for surgery done in procedure rooms, the facility must be licensed, which means they must possess a CON. However, procedure rooms do not require a CON to build. There is no limit to the number of procedure rooms that can be built, and the surgeries performed in procedure rooms are not counted towards community need. In essence, holders of OR CONs can expand surgical capacity without limitation and eliminate the need for further CONs. This is evidenced by just 2 OR CONs being created in all of North Carolina in 6 years, while being the 5th fastest growing state in the country. At least in this specific case, the Certificate of Need system perpetuates a monopoly. How much does this monopoly cost? David French, an independent CON consultant, has run the numbers and finds that just a 10% shift in site of service from hospitals to ASCs would save the North Carolina State Health Plan $53 million and $16 million in state Medicaid expense in just 6 years. In conclusion, CON laws are complicated, divisive, and potentially manipulated. There is no proof they provide better access, quality, or value of care. In the hunt to control costs in modern healthcare, CON laws should be in the sights of physicians, payers, patients, and the politicians who represent them. Thank you for watching my video.